want to thank the organizers again for organizing this very important session and also inviting me, and very kind words from my co-chair. I think I've been given the impossible task to firstly speak after Dr. Nihas, and then on talking about personal experience, and we all know personal experiences are no longer publishable. So I rather draw my attention or your attention or anyone's attention after lunch onto areas that I feel comfortable with. And I'm a pulmonologist, and unfortunately, a lot of my patients are extremely sick. So I sort of sometimes mingle with you guys, ICU people. This is one of my teachers here. And he taught me how to look at credential of my fellow presenter. So I looked up Dr. Niha's credentials and predicted what he will say, and then do a set of slides slightly different from his. And if you forgive me, some of which is, of course, not as good as my previous presenter. And I want to talk about sepsis very quickly to bring you back. I want to talk about pathophysiology, which you all know, and general management, and talk about really the comfortable turf of pneumonia. And you know, sepsis is defined as not definable because it is in simple English, right? So my driver understands this. So he said sepsis is presence of pathogenic organisms or the toxins in the blood and tissues. And I think that should be a tautology, even when we change our jargon. And of course, definition of adult is impossible. And then you look at the definition of septic shock. And this is, I think, one of the very updated attempt, and even published in good journals like JAMA, sometimes rubbish, but on the developing a new definition. And this is a group of very intelligent people, and they didn't invite me, saying sepsis or septic shock is defined as a subset of sepsis in which underlying circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. What a complete set of nonsense. So there's no definition at all, is there? Let's talk about something that we can't define, something that we don't know, essentially the incidence of sepsis. And sepsis is, of course, the leading cause of ICU death and top 10 cause of death in the US. More people die than in the UK. It's always better to live in Europe. The incidence, of course, increasing all the time because of us being more able to save people before we hand them over to ICU. The inflammation in sepsis is, of course, well known. I mean, of course, inflammation is a good thing. My second-year medical student son will tell you, inflammation is designed to help you. It involves upregulation of pro-inflammatory cytokines, TNF-alpha, etc., and chemokines, IL-8, etc. And these will stimulate effective functions of white cells, activate coagulate cascade. And then, of course, if that's overdone, you will die within the first few days because of that. That's usually not the case, but it's so in meningococcal sepsemia, as we all know. And you know the cytokine levels actually correlate with death. This is a paper already touched on by my colleague earlier, but I just want to say that immunosuppression in sepsis is well known. And those of you who don't tell your neighbors because they will say that you have been asleep for the last 10 years. But autopsies showed unresolved septic foci in patients who died in ICU. And autopsies splenocytes show profound suppression, so-called T-cell exhaustion. And of course, then will lead to immunosuppression. In the same paper, it was pointed out very, very importantly, I think, that pro-inflammatory mediators are related to symptoms early in sepsis, while most septic patients go into immunosuppressive state later on and allow opportunistic infection, which can last for weeks sometimes, if they don't die, that is. And this is already been touched on, but I want to just very quickly point out that pathogens with pathogen-associated molecular patterns, PAM, will give PRR and go down possibly pro-inflammatory immune response leading to cure. But a lot of time it would trigger other T cell activities leading to anti-inflammatory responses. And when these are prolonged, you have dysfunctioning lymphocytes and apoptosis, immunosuppression, and therefore immunoparalysis in sepsis. And these are reckoned and now agreed to be very important. I want you to remember, does anyone remember her? No Americans in this room. Poor Hillary, there was apparently before she had made up on when she was running for president, and she was coughing a lot, can't you remember? And then she was bundled into the car. Now, pneumonia is, of course, extremely important, and I don't like my predecessor presenting 2 cases of sepsis, both surgical. Clearly, in Germany, ICUs are different from the rest of the world. Pneumonia is the most important cause of ARDS. 10% of pneumonia patients, CAP patients, will not survive, and a lot of them die. Talk about what's severity. What patients have bad pneumonia, apart from old age and dementia? Men die, nursing home residents die. If you have cancer, liver disease, congestive heart failure, cerebral disease, and renal disease, you're more likely to die. And then you can bundle all this up and add up altered mental state. And if you are a great believer of PSI, I feel sorry for you. Because these are obvious clinical parameters for an unstable patient who are likely to die from pneumonia. And if you are so true believer and add up all these numbers and put into different scores, you know the probability of your patients to die from pneumonia. Now, these are well-known facts since 1997. The British, of course, as usual, try to save money and use CURB 65 instead. If you have confusion, urea higher than 7, respiratory rate greater than 30, blood pressure less than 90 or 60 systolic and diastolic, and greater than 60 or older than 65 years, you are more likely to die if you have pneumonia. And of course, we all know that too. Now, these are the at-risk people, but who else who would therefore need the pentaglobulin? Well, there are other people with bad pneumonia too. MRSA, Legionella, foreign body, cancer-related, COPD, ILD. Now, I don't know about in your country, but in Hong Kong, we have a problem with community-acquired MRSA. And worldwide, and this is the figure, and this is sometimes quite insidious, and it can be seen like influenza-like pneumonia. Now, those cases I see actually present with influenza-like symptoms. 45% could die, and a lot of them go to ICU. Legionella disease, of course, is associated with shower, confusion, and dementia, confusion, and of course, bad pneumonia. And we know this is a bad pneumonia. And foreign body is often missed, right? Foreign body is often missed. And in our part of the world, because Hong Kong people live the longest in the world, you know that. And a lot of demented people here, like, yeah, one of the speakers. So this is a 50-year-old, hemoptysis, chronic cough and chronic right side pneumonia. This is the CT scan. This is what we saw, calcified lesion. We went ahead, pulled that out, and discovered it was actually the part missing from the chicken rice. And this is a lad with pneumonia and a Lego toy. We gave it back to him. He had the full set afterwards. And this is a gentleman with the right upper lobe pneumonia persistently with sepsis. And of course, all you need to do is do a bronchoscopy, and you can see there's right upper lobe pneumonia. These 3 marks, does anyone know what they are? Biopsy marks, actually. And this is a lady with one of my students' mother with esophageal carcinoma who had recurrent pneumonia. And of course, you can see the stent from the esophagus going into the trachea. Now, these are the people who have very bad pneumonia. Sepsis general treatment, well, and I think people know how to treat sepsis in this room. I just want to run through this. I think a very good bundle, but to point out that the paper did not mention anything about treatment with immunoglobulin. The sponsors of this meeting is already very furious. How about treatment of pneumonia with antibiotics? And we all know Lionel Mandel and all this. if you don't know this, sorry, you're in the wrong room and the wrong conference. Back to med school. Now, these are some of the rationales to treat people with pneumonia, ATS and many guidelines. That's not interesting because we do them all the time. How about steroid? My predecessor had mentioned, and rest in peace for it. Steroid, this is, I thought, a good paper. John Moran published and said low-dose corticosteroid therapy in severe sepsis and septic shock remained to have a high probability of treatment efficacy. Shall I read it again? I think it says some efficacy. I think the English means. The second paper by Torres et al. From Spain in 2015 published this paper, The Effect of Corticosteroid on Treatment Failure Among Hospitalized Patients with Severe CAP and High Inflammatory Response. This is up our street, right? What did the conclusions say? 120 CAP patients, high CRP, received 0.5 milligram per kilogram of methylprednisolone, BD 5 days. Now, so that's quite a good dosage of steroid. And the primary outcome was treatment failure, defined as early failure or late failure. Early failure is progression to septic shock, etc. Late failure is radiographic progression or death later. So, in fact, they found less treatment failure in treatment group with a sort of a p-value responsible for the publication, and a bit of hyperglycemia as one would expect. So there's some effect on this. Another group, Christina Bloom's group, published in Lancet 2015, adjuvant prednisolone therapy for treatment with CAP, a multi-center study. Now this showed primary endpoint was time to clinical stability was 1.4 days earlier in the treatment group. So giving steroid will give you some effect in patients with severe pneumonia, with sepsis. Annuals of Internal Medicine, there's a very good review and meta-analysis published recently in 2015. It says, for hospitalized patients with CAP, systemic steroid, etc. I'm going to show in a bigger slide, which says, by using steroid in hospitalized patients with CAP, mortality is reduced by approximately 3%. It's not great, is it? It's not great, and reduced mechanical ventilation by approximately 5%. Again, it's not great. So I'm not sure. How about novel therapy, right? Novel therapy, we've been talking about novel therapy, pantoglobulin's is a novel therapy in sepsis, right? And the last paper on novel therapy in sepsis was published in 2005. I thought it was rubbish. But why? Because everything it mentioned didn't work. Antithrombin 3, of course, doesn't work. Human recombinant activated protein C, of course it doesn't work. If it works, they will be sponsoring lunch day, won't they? And then GM-CSF, possibly, if you look at the function of GM-CSF, it activates and induces production of neutrophils and monocytes, right? What it does is that with such sepsis, a patient with sepsis treated with GM-CSF have been found to have restoration of HLA-DR expression, something that we found in the immunoparalysis. And patients have fewer ventilation days and shorter hospital stay and ICU stay. Now that's promising. That needs to be confirmed. Anti-PD-1. Now that is a very sexy subject if you're a pulmonologist because it treats cancer. Now we don't worry about sepsis, we worry about cancer of the lung. But in this room, I better revert back to say that it can reverse T-cell dysfunction if you get anti-PD-1. And it's been shown that anti-PD-1 had effect on, raised PD-1 level had been overexpressed on circulating T cells on septic patients, and that is associated with increased secondary infection. So anti-PD-1 might work. Interleukin 7, godfather, pluripotent cytokine, had been shown to induce proliferation of T cells. Now, this had been found, as we discussed earlier, depleted in immunoparators. So it may be useful, and it's been shown that it could increase circulating CD4 and CD8 cells, increase in size of spleen, and other parameters in some patients treated. So that is a useful drug. I'm now going back to what I should be talking about. Immunoglobulin. My predecessor is far more eloquent and better looking. But I'm just going to dance through this to say the use of immunoglobulin is common practice in this part of the world. Hong Kong is an affluent society. The relatives say, how come you haven't given immunoglobulin? You shake. And it's been talked on for a long time. IVIG exert a significant effect on mortality in sepsis and septic shock, with a trend in favor of IgAM, probably sponsored by pentaglobulin. Now, this is another paper saying IVIG administration, when used in combination with adequate antibiotics, improves the survival of surgical ICU patients with intra-abdominal sepsis. So that's useful. And another paper here says polyclonal IVIG reduces mortality in severe septic shock and sepsis. But high-quality research did not confirm this. In Japan, they have a very interesting study that was published in 2015 saying the use of IVIG in patients with pneumonia showed no benefit amongst 8,264 patients. And I think that kills it, certainly in Japan. How about Cochrane? Well, I don't know why this guy's smiling when I mention Cochrane. Now, Cochrane review had been done on several times, 1999, 2002, and 2010. There have been 43 studies that met the inclusion criteria in this update, out of 88 studies on IVIG in sepsis. And you have to bear with me because I don't like words, but it says polyclonal IVIG reduced mortality amongst adults with sepsis, but this benefit was not seen in trials with low risk of bias. For neonates with sepsis, there is sufficient evidence that standard IVIG does not reduce mortality. For IgM-enriched IVIG, the trials on neonates and others were small, and the totality of the evidence is still insufficient. Now, bearing in mind there was 2010, I think some of the papers we read earlier might shed other impact on this conclusion. I don't need to talk about I don't need to talk about IgM and pentaglobin here. IgM-enriched polyclonal immunoglobulin actually had been found to be useful among experimental animals. And data in another study show is also useful for multi-resistant pathogens in 100 Greek patients with septic shock. Now, that's very important, and I don't know where you come from. If you come from sleepy Cambridge with no bacterial resistance, fine. If you come to Asia, India, mainland of China, we have an issue. We have an issue of huge bacterial resistance, and we come sometimes in our ICU, we see Acinetobacter, which is completely resistant to everything. So how do we treat them? We clean them. We wipe the patients. This is not important. Not important. This paper talked about an experience that indicated early use of IgM may be associated with survival benefit in patients with septic shock. Now, all these papers have been talking about IgM. In fact, I wonder whether it's because IVIG never did this sort of study. Another paper showed IgM reduced Apache score, overall mortality, and 28 CFR. So who will benefit from pentaglobin then? We heard from a colleague that in Hamburg there is this kind of practice, but is it data proven? I don't know whether anyone had encountered SARS patients. Can you raise your hand if you have encountered SARS patients? These are Asians, and me. And we published a first paper, and I thought I would die. So actually, I wrote back to the editor in New England and say, I can't be bothered to write this because I will die in the next 48 hours. He said, can you write it before you die? So this is what we found, and in Hong Kong, we went through a lot. A lot of our colleagues died. And the symptoms of SARS, I think we all know, is like instantaneous. The patients always tell you, doctor, I have a fever. It's like, phoom, it comes on. They cough the lungs out. They come in with a fairly normal X-ray. The next morning, the X-ray shows like this. So this is what we see SARS. Some have terrible diarrhea and vomiting. But now we only have SARS like this, and the coroner is the only coroner we can find in Hong Kong. And the masks, we left behind a lot of stuff. But when we look back to the time when we had SARS, so you look at the time, and it was not really that funny because the whole of Hong Kong was actually like this. And so I just want to mention some experience with SARS. Now, this is what we call a good responder. This is a patient who came in day 1 like this, day 7 like this, day 14 like this, day 21 like this. In those days, these guys were treated with steroid and ribavirin. Now, would we do that again? I don't know. But this is a good case. This guy gets sent home day 21, no complication, comes back to follow up. 3 years later, we say goodbye to you. We don't want to see them again. But some of these don't. Some of these carry on and won't get better. Whatever you give them, what do you do? Well, we had looked into this using pentaglobin. This is a personal experience, and you are faced with a guy who's being ventilated for 21 days, bilateral whiteout, fever. What do you do? Well, we have 12 of those patients in Hong Kong at that time. And these people have been given methylprednisolone again, and don't have anything else. They have, and then the X-ray was getting worse and worse and worse, and then given pentaglobin, and then things seem to settle. Now, of course, that was only an experience paper, and not even a trial. But it did show that pentaglobin seemed to be associated with improvement for these desperate people. When they first come in, they got worse. You give them pentaglobin, they seem to be better. That is not science. That's an observation. So who needs adjuvant therapy in sepsis secondary to pneumonia then? Who needs that? I'm going to show you some pictures. 32-year-old athlete with right lower lobe pneumonia. Why would she need it? She runs away with your Augmentin and Citromax from the outpatient clinic. Doesn't need it. How about this guy? 52-year-old severe pneumonia, gangrene of the left foot. Left or right? Left foot. Right foot, yes. It shows that the patient is still under my care. and bad pneumonia, sepsis. Would you give him? Dr. Nias would definitely give it, from what I heard. This is somebody. Would you give this lady pentaglobin? Would you give this guy pentaglobin? SLE patient, respiratory failure pneumonia, with CMV, pneumonitis. 85-year-old MRSA pneumonia, type 2 respiratory failure, pacemaker in situ. 59-year-old man with multi-organ dysfunction, multi-organ failure on ECMO. Notice, fresh case. 55-year-old invasive aspergillosis and type 2 respiratory failure. Would you give him pentaglobin? Would you give him IVIG? 56-year-old, female, not man and woman. Female with H5N1, poor Malaysian patient came to Hong Kong, caught this. H5N1 pneumonitis complicated by Staph aureus, and we couldn't see the lung. Would you give her pentaglobin? 32-year-old Indian man with malaria and multi-organ failure came to Hong Kong, Indian banker, came to Hong Kong, had malaria, septic shock, absolutely no response to anything else, SaO2 on 100% oxygen, 60%. Went on to ECMO, got better. So I just want to now leave you with the questions, because I don't have the answers. I want to say sepsis is not a definitive diagnosis, it's a consensus. So we don't know when to give it. I just want to remind you sepsis is common and lethal. And we still have major problem. Clearly, antibiotic therapy is not adequate on its own. Anti-inflammatory treatment using steroid is not effective enough, even if it is. And novel therapy needs to be explored. And pentaglobulin might be useful because IVIG had been declared to be not so much. And of course, we need more research urgently. And people say that, and I say this. How low has President Obama gone to tap my phone, tap my phone during the very sacred election process? We don't need any evidence. Well, we do. Thank you.